Hi, good afternoon. Hi, good afternoon. Good afternoon. It's another Wednesday. This is Patience coming your way with Funds Nclex review. Today, I'm gonna talk about prioritizing client care. Prioritizing client care. And the topic is leadership, delegation, and emergency response planning. And I'm going to start with healthcare delivery system, healthcare delivery systems. So I want you to follow me as I start. So healthcare delivery systems. I have managed care. What is managed care? So managed care is a broad term used to describe strategies used in the healthcare delivery system and systems that reduce the cost of healthcare. So anytime you hear of managed care is all about reducing healthcare costs. And we can all testify about healthcare costs in America, especially. So we have clients care is an outcome driven. So managed care is also a client care outcome driven move, and it's managed by case management process. So we use case management to manage the client payment methods. So we have case management. What is case management as well? Case management is a healthcare delivery strategy that support, is a healthcare delivery strategy that support, give me a minute. I just want to share my screen on the other side so that those who are on the other side with me, those who are on Zoom, will be able to view the structure. So case management is a healthcare delivery strategy that supports managed care. It uses an interpersonal healthcare delivery approach that provides comprehensive client care throughout the client's illness, using available resources to promote high quality and cost effectiveness or cost-effective care. So that's case management. So case management and managed care use case management approach, and case management approach is using interpersonal or interprofessional collaborative effort to be able to help the client with quality of care and cost of care throughout the time period that the client stays in the hospital, and even if the client is at home and still needs care. So case management will include assessment and developing a plan of care, coordination of all services, referrals, and follow-up care, especially for patients who are being discharged and they are going home and they are going to need home health services. So case management steps in, or patients who are going to be discharged and they have no places to go and live. Case management does referrals for them. And then those who also need nurses to visit, like the visiting nurse service, the case management will also do that. So who is a case manager? A case manager is a professional nurse. A case manager is a professional. A case manager is a professional nurse who assumes responsibility for coordinating the client's care at admission and after discharge. So a case manager is a professional, and the case manager will establish priorities and a plan of care for the clients. And they does the coordination, they does the interprofessional consultation. So if they need to refer the patient to a home health agency or to a visiting nurse service agency, they will do that, the case management. So the case management, if the patient also need insurance, they have knowledge about health insurance, and they does all the referrals for the patients. So whilst the patient is in the hospital and is being discharged home, case management is part of discharge and planning process. Now we have health insurance. There are state and federal insurance plans. So at this point, I'm going to talk about the various health insurance plans, which we usually can get questions on the Nclex. So the insurance plans that we have, the aim of the Affordable Care Act was to reduce the amount of uncompensated care the average US family pays for by requiring everyone to have health insurance or pay a tax penalty. If we remember a couple of years ago during Obama's regime, we had the Family Care Affordable Care Act that was started, and everybody was required to have health insurance in America. So everybody was required to have health insurance in America. And if you don't have health insurance, they wanted to make it a mandate. So the mandate was that you either have health insurance or you pay tax penalty. When you file your taxes, they give you a penalty to pay because you don't have health insurance. So, and we have so many of the insurance companies that provide the health insurance for people. One second, please. Okay, have a seat. All right, so let's talk about the various types of health insurance. We have the marketplace. We have many insurance companies that provide marketplace health insurance. And these include Aetna. We have the Aetna health insurance. We have the Blue Cross Blue Shield. We have the Cigna. We have the Cigna, Humana, Kaiser, United Health, and TRICARE Humana. These are all marketplace insurance, and the types of insurance plans they carry include maintenance organizations, which is health maintenance organization, HMOs. So when you see HMO in the Nclex, it tells you it's a health insurance management organization. So they have preferred organizations, which is also PPOs. So this marketplace insurance companies that I mentioned, Aetna, Blue Cross, Blue Shield, Cigna, Humana, Kaiser, United Health, and TRICARE Humana, they come with health insurance plans. And those health insurance plans are managed by Health Maintenance Organization, which is HMOs. And then they have the preferred organizations, PPOs, and exclusive provider organization, EPOs, point of service plans, POS, and high deductible health plans too, and health savings account. These offer varying options in terms of insurance coverages and out-of-pocket costs and premiums. So if you want to enroll with them, they tell you whichever one will match you based on your income. They screen your income first and they know which one you qualify for, and then they get you enrolled for that particular one. So now let's look at Medicare. So Medicare is a federal health insurance program. So Medicare is not part of the marketplace insurance. It's a federal health insurance program for persons aged 65 or older, certain younger people with disabilities. So people who are born with disabilities, they may have Medicare as well. And people with end-stage renal, they need dialysis for life, requiring dialysis and renal transplant. They can get covered with Medicare. Remember, I said Medicare, and people and certain premiums are also attached to each part of it. So we have different types of Medicare. Now we have Medicare Part A, Medicare Part B, Medicare Part C, Medicare Part D. Now let's see what is Part A, B, C, and D. Part A covers hospital stays. So if you get admitted in the hospital, Medicare Part A will cover you. You can only get one of this. You cannot get all of them. So if you get enrolled in Medicare, which is a federal health insurance plan, you can only get, let's say you get Medicare Part A. So Part A will cover you when you get admitted in the hospital. If you are in the nursing home, if you are under hospice, and some healthcare, home healthcare agencies, Medicare will pay for it. Now, Part B helps you pay for services that are not covered by Part A. So services that are not covered by Part A, Part B will help you pay for them. So we have Medicare that usually covers 80% of approved services, and the remaining 20% is the client's responsibility and supplemental insurance needs to be obtained. So Medicare Part B will pay 80% of your care staff. So if they admit you in the hospital, Medicare Part A will pay everything. But if you have the Part B, like I told you before, they screen your income, your job, and everything. So if you qualify for Part B, you will have a 20% to pay. So if you have a 20% to pay, Medicare Part B will pay for your hospital bill. If you're on dialysis, they'll be paying 80% of your care. So each time you go for dialysis treatment, they'll pay 80%. The 20% is for you to pay. So people do get other supplemental health insurance, like the marketplace, to cover the 20%. Okay, that's what Part B is supposed to do. Part B is supposed to help take care of the cost if you don't have Part A. But if you have Part B, you only pay 20%. You can decide to pay it out of pocket, or you get a marketplace insurance to cover. Part C, Medicare Part C, a health plan offered by a private insurance agency that contracts with Medicare to supplement coverage. So Part C is a private insurance agency. They contract with Medicare, and then they offer the supplemental coverage, or they supplement patient coverage for care. Part D cover prescription medication needs. So Part D only cover prescription medication needs. So if you're on blood pressure medication for the rest of your life, you will need Part D. Part D will cover you for the prescription every time you need the medication prescription. So Medicaid. I have been talking about Medicare. Now, Medicaid. So Medicaid is a joint federal and state program. Medicaid is a joint federal and state program that provides health insurance to eligible low-income adults, children, pregnant women, elderly individuals, and people with disability. Concerns associated with this program is fraud and abuse. A case manager needs to know how to complete insurance states and federal application, and be astute observant enough to know if an individual is reporting correct information. So with Medicaid, Medicaid and Medicare are both federal funded. They are federal insurance. So Medicare is supposed to cover 65 years and older and people with chronic illnesses. Medicaid is supposed to take care of the younger generation. So we have the adults, the pregnant people, the younger people. So in Medicaid, you can be working. You can be a young person in your 30s, in your 40s, but because your income is not enough to cover, you get Medicaid. You get free care from the federal funding. And Medicare is a collaborative effort of federal and states to help provide healthcare for people in the states. So the concern with Medicare is fraud and people not reporting their accurate information. So in this one too, you will need a case manager to step in and be able to provide accurate documentation or proof why people and how or why people qualify for Medicaid. So for people who qualify for Medicaid, they get screened. Now, critical pathways. I have seen several students think that critical pathway has to do with disaster and emergency management. Now let's look at what critical pathway is. Critical pathway is a clinical management care plan for providing client-centered care and for planning and monitoring the client progress within an established time frame. Critical pathways is an interprofessional collaboration and teamwork that ensure shared decision-making and quality client care. Okay, so critical pathways, they are based on evidence-based practice, and they include evidence based on medical practice, budgetaries, organization, and system-wide information. So critical pathways are based on evidence, clinical evidence. So it is mostly being used by organizational leaders who use evidence. They use evidence-based practice. So if they see that, okay, if we have a patient who presents with COVID and this is what it worked, the high flow nasal cannula was able to work, and they put it to testing, it goes through a research. The research into patients and how they get it. Or let's use the monoclonal infusion that they just started as an example. So they research, and then after the clinical studies, they realize that patients are getting it, but it's not patients who have advanced to shortness of breath and to complications with the COVID that get it and survive. So they stop that. Those patients, if you have developed shortness of breath, you don't get it. But if you have not developed shortness of breath and you are younger and based on your age, you qualify for this, or for some of the reasons they screen you and they see that you are a good candidate for monoclonal antibodies, they give you. But if you develop shortness of breath, you don't get it. So this is evidence that they have gone through a research process and they have seen that this is how it works. So leaders will implement it based on the fact that they have the evidence and they use a system-wide information. So the information is all over New York. So New York Health and Hospital will say, okay, so we have a system-wide information that this is what we are going to use and this is how we are going to implement it. So this is how critical pathways work. So critical pathways are used to ensure medical care is consistent with budget constraints. So if there's no money in the facility, but the kind of care they still give will fall within a good standard of practice. And it also allows providers to care for more complex clients. An example is some ambulatory practices, they have critical pathways for certain conditions like blood pressure monitoring or urinary tract infections. So these are critical pathways they use by organizations. So mostly critical pathways has to do with organizational leaders trying to ensure that their practice goes with their budgets. Now let's look at a nursing care plan. A nursing care plan is a written guidelines and a communication tool that defines the client's pertinent assessment data. So when you assess a client and you get the client's data, you get the information, subjective and objective data from the client. You use that one to come up with a problem. So you have gathered information from the patient, and after you have gathered the information from the patient, you should be able to use that one to come up with a problem. What is the problem from this information the patient is telling me? What is the problem? And you now, after you have now come up with a problem, then you come up with a nursing diagnosis. So if I diagnose you that because you are bedridden, in the next 4 days, you are at risk for developing pressure ulcers. So if you are at risk for developing pressure ulcers, that will be my diagnosis. I'm diagnosing you as a patient at risk for pressure ulcers because you are bedridden, you are not moving. Now I'm going to put up my goal. What is my goal? So my goal with this will be for me to try to prevent the pressure ulcers from coming to pass or from you getting it. So trying to prevent the pressure ulcers, in an attempt to try to prevent the pressure ulcers, I'm going to put in my interventions. and then I have expected outcome. My expected outcome is for sure to be a positive one. So this is how nursing care plan works. And the plan is supposed to enhance interprofessional continuity of care by identifying specific nursing actions that are necessary to achieve the goal of care. So you identify nursing actions that are necessary. So if I attend the patient every 2 hours, it's a nursing goal. If I provide good nutrition, if I help the patient get out of bed to sit for 20 minutes a day, for 3 times a day, like out of bed schedule, all those things are good that you can put in place. So the care plan is modified as the client's condition changes. So as the client condition changes each time, they modify the care plan. So if I'm able to achieve that goal within 4 days that the patient don't get pressure ulcers, I am good. I am good. So I keep the patient in that schedule. But if 4 days the patient developed or the patient was already having pressure ulcers, and I'm trying to keep it as clean as possible, or the patient is incontinent, the patient is not able to use the bathroom, I try to keep the patient as dry as possible. So it's modified based on patient improvement. Now let's look at nursing delivery systems. We have functional nursing. So nursing also have a delivery system. We have the functional nursing, and functional nursing involves a task approach to client care, with tasks that are being delegated by child nurse to individual members of the team, functional nursing. And this type of system is a task-oriented, and the team member focus on the delegated task rather than the total client. So if I come to the floor and we have 30 patients, and they said each nurse is supposed to have 6 of them. So when the child nurse delegates to me 6 patients for my shift, I focus on that. I don't leave my patients and then I go do other patients' care. You can help. It's a teamwork. It's a 24-hour continuity of care. It doesn't mean I cannot take care of the other patients, but my assignment is for me to take care of 6 patients for the next 12 hours or the next 8 hours. So that is where I fall, and those are the patients I'm going to take care of. If my co-nurse goes on break, I take responsibility. So this is the functional approach, and is supposed to give a result in fragmentation of care, supposed to have like everybody being accountable to the patient, and every team member is accountable. So team nursing, the team nursing is led by a registered nurse, which is the team leader. Let's use the child nurse, for instance, and she's responsible, or he is responsible for clients, analyzing client data, planning and evaluating each client's plan of care. So the team leader, let's say you have the nurse manager on the floor, they do all this analyzing and planning data. So each staff member is accountable for client care and outcomes of care delivery in accordance with the licensing and practicing of their scope of practice. So if I am an LPN on the floor, they will have a particular assignment for me. I will take stable patients, and the patients that are unstable, the RNs will take them. So team nursing starts with the team leader, who is usually either the head nurse, child nurse, nurse manager. They start all the processes, and every nurse on the floor is a team player. So you play a team role. Now let's look at relationship-based practice. Relationship-based practice, that is primary nursing. Relationship-based practice is concerned with keeping the nurses at the bedside, actively involved in client care, while planning goal-directed individualized care. So we have one primary nurse is responsible for managing and coordinating the client care while in the hospital and for discharges. So while the patient is in the hospital, a nurse is responsible for planning, coordinating the client care, and an associate nurse cares for the client while the primary nurse is off duty. I just said that. So like the nursing homes, we have regular staff on the floor. So if I am a regular morning staff and I am off today, you know, if I am making noise, if I am a regular noise and I'm off today, then I delegate or another nurse that come on duty is responsible. Client focus. Client focus. So this is also known as total care or case method. So the registered nurse assumes total responsibility for planning and delivering of client care. And this is done in 24 hours period. That's why nursing is always a 24-hour nursing care. You never have like nursing without continuity of care. So nurses are supposed to come over and take shift, and they assume responsibility. Now, professional responsibility, accountabilities. This is the process in which individuals have an obligation or a duty to act and are answerable for their choices, decisions, and actions. So if you pass your Nclex and you come out as a registered nurse on the floor right now, you will have the obligation or the duty. That's why when there's negligent or malpractice lawsuit, they ask a question: was their duty owed? So the moment you accept to work in this facility and you come today and they assign you 3 patients, you owe the patients a duty already. Okay, so and you are accountable. You're supposed to take decisions, which patient to see first, who to delegate, and who can wait. So, and this has to fall within your scope of practice. So if I am a registered nurse and I come on the floor and you are a patient care tech and you are on the floor, I don't wait for you to go and give them medication because it's my responsibility. It's not under your scope of practice. It is in my scope of practice to give medication. It's in my scope of practice to assess the nurse or to assess the patient. I'm sorry. It is my scope of practice to assess the patient, not the tech. Okay. Now, let's talk about leadership and management. Leadership and management. So, leadership and management approaches. We have the types of leaders in nursing. I'm just going to mention them. I'm not going to discuss them. We have the authoritarian leader who gives authoritative, they authorize you. We have the democratic leader who is participative in management. The democratic leader allows you to make your suggestions as well, and they take your decisions as time goes on. We have the laissez-faire leader, and they assume a passive role, non-directive and inactive approach. They leave you to take the decisions. The decision making is left to the group. So you are on the floor, I wait for you to make the decisions, and I go by what you say. We have situational leaders. We have people that assume leadership roles because of situations. For instance, the nurse manager just had an accident and is going to be out for let's say 2 weeks, and we have people that they step in to act as the situational leaders. So these are people that come in as situational leaders. Situation demands that you become the leader. So we have the bureaucratic leader, and the leader, this one believes that the individuals are motivated by external forces. So they believe that if they will rely on organizational policies and procedures to be able to make decisions. Those are external forces to drive their leadership skills. Transformational leader. Transformational leader focus on using the organization's shared vision. So they try to encourage their members so that everybody participates and we achieve the organization's vision. So the organization's vision is to be able to take care of 50 patients a day. So for us to be able to take care of 50 patients, we have the manager leading the team. So the manager is going to encourage the members, is going to encourage the workers. It is because of your approach to patients. It is because you get these patients on time that make the patients to come more. So we are supposed to achieve 50. So we have been able to achieve 50 because you guys quit your job. So transformational leadership, they try to encourage members and they all work towards achieving the goal of the organization, or they work towards achieving the vision of the organization. So if the organization sees homeless people and they allow them to sleep all day, that's the vision. They take them, whether they have insurance or not, they're going to take them and they have them sleep all day and all night. We have the servant leader. The servant leader is the one that chooses to rather be the one serving, not to take the lead. We have the problem solving process and decision making. So problem solving approach is obtaining information and using it to reach acceptable solutions. So you are a leader and they report to you there's a problem on the floor, you get more information. You do a root cause analysis to be able to get information to solve the problem. Then we have types of managers. We have the frontline managers. I'm going to run over this. We have the middle managers, nurse executives, they are the top leaders. We have now we have power, those in power. So effectiveness leaders use power to improve delivery of care and enhance professional management. So let's look at policies and procedures, okay? Policies and procedures. So we have policies and procedures. Nclex will want you to know, or Nclex will question to see if you understand that there is the need for policies and procedures. So policies and procedures are guidelines that define the organization's directive and their course of action. So guidelines and directives that direct our course of action. Those are policies. And procedures are based on policy, and they are defined methods for task. So procedures define the method of task, the method that we use to be able to achieve the policy set up by the organization. So the policy said you have to come to work at 7 a.m. And now what procedure do I use to come to work at 7 a.m.? When I come 7 a.m., there is a procedure for me to do. I have to attend the huddle before I start the day. So procedures come. Policies come before procedures. So policies come before, excuse me. Policies come before procedures. So policies are based on defined methods of the task. And protocols prescribe a specific course of action for a specific type of client problem. We have centralization, which is the making of decisions by a few individuals at the top of the organization or by the managers of the organization or department or unit in the building. So we have evidence-based practice. Evidence-based practice is a research, this is a research and it's an important role of the professional nurse. Research provides foundation for improvement in nursing practice. So evidence-based is when they get the evidence, when they put something to test, and they realize that this nursing theory, before a patient become agitated and leave, the problem is that the patient had waited for too long and they have become frustrated, they can no longer take it. Or another policy, another theory will tell you that because a patient is sick and can no longer endure the pain on themselves, or they can no longer manage with their problem. That's why they come. So theories and evidence-based practice go together. Theories serve as a framework for evidence-based practice. So evidence-based practice requires that the nurse-based nursing practice on the best and most applicable evidence from clinical research studies. So all these things are done through research. So the nurse should be able to alert to clinical issues that warrant investigation and develop a research questions about the problem. So let me give you an example of evidence-based practice. So for instance, hand washing. So we used to do hand washing and they will tell you, oh, hand washing is done this way, that way. Now they have come up with a change. Okay, hand washing should not be up to 20 minutes. It should be 15 minutes. It should be after you finish singing happy birthday to you. That is the procedure for hand washing. And you should do it in this way and that way and that way. And now today they have come back and said, oh, that method have changed. So based on research, that one was done 5 years ago. Right now, we don't do that. Research have proven that if we do it this way, it is going to be more effective for us. That's what evidence-based practice is. So you as the nurse, you adapt that new evidence, or you have the nursing leadership come to give you in service and tell you that this is no longer done like this. This is how it goes. Even though we have the old maid syndrome, we have people that always say we used to do it this way. But for the purpose of the Nclex, understand that evidence-based practice is research that has been proven to work, and they now bring it to your practice. So as a nurse, you will always use evidence-based practice. Quality improvement, also known as performance improvement. Quality improvement focus on processes or systems that significantly contribute to client safety and effective client care outcomes. Criteria to use to monitor outcomes of care and to determine the need for change to improve the quality of care. So we have the quality improvement process or systems that may be named quality assurance, continuous quality management, or continuous quality improvement. The quality improvement process improves the quality of care delivered to the client and safety of healthcare agencies. Change process. So change is dynamic. Nobody ever wants change. Sometimes we have problem accepting change, but we have the various process of change by Lewin's basic concept of change process, and this includes 3 elements. Excuse me. It includes 3 elements for successful change. So Lewin came up with a concept telling us that before you can make changes, there has to be 3 elements that has to apply before you can make changes. So if I am the nurse on the floor and this is how I did it, and now you have come as the new manager, you want to make changes, or as the new registered nurse, you want to make changes. There are 3 processes that Lewin's model have gone through and have proven that these are the methods that work. And nursing evidence have adapted it, and they are now using it to implement change. So Lewin said, change goes through a freezing process, and that is the first process. And during which the problem is identified, that's the freezing process. At this stage, you identify the problem and individuals that are involved in the problem. You gather facts and evidence to support the basis for the change. So you gather facts to support the fact that you need change. This is not right. We need to change it. Now that's the freezing stage. You have identified that there's a need for change. You have people that are involved. So on which unit do we need to change? So right now, my unit, my facility, we're making changes. So we just realized that at this point, we need to make changes to one of our floors. So we have to take the patient out to another unit. We have identified the problem and whoever is involved and how we can deal with it. That's the freezing. During the moving and changing phase, we have the second part of it, that is the moving and changing phase. And this is when the change is implemented. So we have started making the changes. It's taking effect right now. Refreezing is the last phase of the process. And at this stage, the change becomes stabilized. At this stage, we have stabilized it. So you can only have a pushback in the unfreezing state, and the unfreezing stage, you can have a pushback there. And when it comes to the moving phase, you can have a pushback there, but not too bad. But in the refreezing stage, that means the change is completed, it is established and cannot be changed, it is done. So we do have conflict that come in with changes because people don't like changes. So types of conflict, we have the intrapersonal, which occur within a person. Sometimes you have a conflict within yourself. Sometimes you have a conflict within yourself. So conflict that you have within yourself is interpersonal conflict. And interpersonal, we have the intrapersonal, that is within yourself, intra, within me. And then we have the interpersonal. Interpersonal is when you have a conflict with another person or among clients, nurses, or other staff members. So that's interpersonal. Then we have organizational, which occurs when an employee confronts the policies and procedures of the organization. So you can have a conflict with the organization's policy. Models of conflict is avoidance, accommodation, competition. Those are the models of change. They define the models of change. Now, roles of healthcare team members. We have the nurses' role as a fellows, the nurses' role as fellows, the registered nurse, the registered nurse. So as a registered nurse, your role is to promote health and prevent diseases. Your role is to promote health and prevent disease. That's why when those patients come to you, your role is to give them medication, provide this, provide comfort measures, provide in everything you can do within your scope of practice to prevent illness and disease and to promote their health. So if they came in with a devastating health, they are being discharged today, you have promoted their health. They provide comfort and clients and care to clients. So you provide comfort and you care for the client. When the patient is dying, you have to make sure the patient dies peacefully. Then they make decisions. Nurses make decisions. They act as client advocates. Advocacy role, never forget, they lead and manage the nursing team. So if you're on the floor with the daily, anyway, I had a PA who told me nurses control the scene, because every morning when we called the nurses huddle, he will always be like, okay, patients, you guys control the scene. So nurses control the scene. So they lead and manage the nursing team. They lead and manage the nursing team. They always carry information to you. They will always look for nursing, to look for this, to do this and that, to answer questions and to deal with the patient. They serve as case manager. So the case manager too is a registered nurse, is a professional nurse with advanced degree. So case management is a specialty in nursing that the case manager as a person goes in for a further education and is part of nursing. Function as a rehabilitator. So you also function as a rehabilitator. Communicate effectively, educate clients, families, and communities and healthcare team members. Act as a resource person. You are a resource person that everybody comes to. So the patient has to use the bedpan, the doctor can call you, the nurse. The patient wants to go to the bathroom, they look for you. The patient needs water to drink. The patient wants food to eat, they look for the nurse. Everything, you are a resource person. The patient needs referral to medicate. They ask you questions. Where do I go? Where do I start from? The patient need to register and be seen by a doctor. They ask you, do you think I can be seen by a doctor? So you become a resource person as a nurse. Allocate resources in a cost-effective manner. So you should be able to tell the patient, okay, when you go to this particular insurance company, this is how it should be. That's why you need to know the managed care. You need to know Medicare Part A, B, C, and D. And you also need to know Medicaid. The primary health care provider. Who is the PCP, primary care provider? So they are the doctors, they are the physicians, physician assistants. They conduct examinations, perform diagnostic procedures, assist in operating rooms, emergency department, and treatment. They are also certified as licensed physician assistants, and that's it. We have the nurse practitioners. The nurse practitioners are advanced practice registered nurses who have gone further to do their masters, and they did nurse practitioner course, and they come up with a certificate. They get certified with a license to practice as practitioners. Then we have the physical therapists. Physical therapists, they also do their job. They examine, they assist in examining, testing, and treating clients recuperating from injuries. Clients that are recovering. If you had a stroke and you are recovering from the stroke, physical therapy will help you with exercises and everything. If you had like trach and now you have to start eating, we look for the speech therapy. You have to start eating and talking. We look for speech therapies, and we look for nutritionists for you to try you to start swallowing the food, to test your ability to swallow. Then we have the continuing care nurse. They coordinate discharge planning for patients. So we have nurses that does coordination of discharge planning. Now we have the chaplain. They deal with the spirituality of patients. We have the pharmacists in the healthcare team as well. we know what they do. They dispense medication for us. Then administrative staff, they are the support staff. We have the clerks, the unit clerks who will do registration for patients, who will open patient visit. They are the supportive staff. Then we have interprofessional collaboration. Client care planning can be accomplished through referrals, consultation, interprofessional. So from nursing to medical, from medical to social work, from social work to case manager, is interprofessional, from one profession to the other. We all come together and play a role to help our patient. Now, report. I'm going to talk about report, which I know I had discussed it in one of the videos, but I'm just going to go over it quickly. So report is supposed to be given every time there's a shift change. We have the change of shift report, handover report. We have the telephone report where you talk on the phone and you record report for your other nurses to come and play it and listen to the report you are given. So the next shift coming, they come and you tell them, I have a phone report recorded. You can go over and listen to it. We have the transfer report. So if you are transferring a patient from one unit to another unit, you have to give a report. You're transferring a patient from one hospital to another hospital, you have to give reports. So it's all part of nursing function to do. Now in the process, we have communication. We have the SBAR. SBAR is a communication tool where you use that to give report. So if you have a patient, you have to report the patient to the nurse, or you have to report the patient to the doctor. So you have to give the situation of the patient. You have to give the background information of the patient. What is it about this patient you are telling me? You have to give me what you assessed from the patient and what you found, and then you have to give a recommendation. Recommendation is what you think should be done. So you assess this patient, you see the abdomen distended, lower, the patient has nausea, vomiting, the patient is having colic abdominal pain, you think it's the appendix, you have to tell the doctor it does seem it's appendicitis, and if you could get the patient some morphine for pain. So we have interprofessional consultation. These are consults, you know, when you are at the floor and they need the surgical team to come and consult and see a patient, interprofessional. So I'm a nurse, but I think this patient needs renal consult. So they put it in, you have the administrative staff support you to put it in for renal consult, and the patient is seen. Discharge planning. Discharge planning is basically done by the registered nurse. Registered nurses, you do discharge planning. You do discharge planning. I'm focusing on registered nursing because this is for nursing, and the LPNs are not supposed, they are not responsible for discharge teaching and discharge planning, even though they participate in re-teaching or re-educating, but they are not in charge of discharge. So discharge planning begins when the client is admitted at the hospital or the healthcare facility. So the moment you receive the patient right now, escort tells you the patient is being admitted to your floor. That's when discharge planning starts right away. So you go through a series of process, you have the care plan, you do everything, but you make sure within the first 24 hours, the patient admission process is completed. You, the nurse, have to do an initial assessment, get your data well organized, documented, and assess the patient head to toe. Please don't assess the patient head to neck because the patient came in with head injury and has a neck collar. Don't stop there. You're supposed to see patient head to toe. You're supposed to ask patient if patient is verbal. So you have to do initial head to toe assessment. So we have the delegation as well, an assignment. I spoke about that. I'm not going to talk about it in this video. It's in the other video. Just look for delegation and assignment and you'll get that video. We do have principles that guide you when you delegate. You have to delegate the right task, the right person. We have 5 rights of delegation. So the 5 rights of delegation is the right task, the right circumstances, the right person, right direction or the right communication, and the right supervision and right evaluation. Those are the 5 rights of delegation. We also have principles and guidelines for delegation. This tells you what you can delegate and what you cannot delegate. Then we have time management. It's a technique that you design to complete tasks within a defined time. This is where prioritization comes in. So when you take your shift report and you have 5 patients, and one need to use a bedpan right now, one need wound dressing, one need to go out and take a walk, or one is waiting for the physical therapy. Which of these people will you attend to first? Time management. You have to be able to group these patients to manage your time wisely. This is not it's not necessarily for you to say this patient is ABC and you start prioritizing ABC. You have to manage your time. Use this. So time management. Now we have the principles and guidelines that you use that. So prioritizing care. You prioritize care by deciding who need or which need or problem requires immediate action and which ones could tolerate a delay until a later time because they are not urgent. So that's what I just said before. You have the guidelines to prioritize. You use guidelines. You set priorities for client teaching, priorities of how you are going to teach the client. Choose another one. I'm sorry. Okay. So I'm sorry. So at this point with the prioritizing care, you determine the client with immediate learning needs and you give them the teaching they need. You identify the type of learning they need. As the patient needs to know about their medication, as the patient needs to know about how to do follow-up with their doctors. Do they need to know about their schedule, their routine daily schedule in the facility? So you do prioritizing, or you prioritize the care of all your patients when you take over the shift. Prioritizing care when you're caring for a group of clients. So when you're caring for a different group of clients, you identify the problems of each of the clients and you review the problem and the nursing diagnosis for each of them. So the nursing action is to assess a group of clients in order of priority. And the nurse is assigned to the following clients. The order of priority assessing the client is as follows. A client with heart failure. So I think this is a question. This is a sample question that I have in here. I said that the nurse is assigned to the following clients. The order of priority in assessing the client is as follows. A client with heart failure who has a 4-pound weight gain since yesterday and is experiencing shortness of breath. That's patient A. Now, I'm going to have you listen with me or make answer options with me with this patient. A client with heart failure and the patient has gained 4 pounds since yesterday. Just yesterday and today, the patient have gained 4 pounds and is now having shortness of breath. So you have just arrived on the floor. A 24-hour post-operative client who had a wedge resection of the lung and has a closed chest tube drainage system. Well, this patient had a procedure yesterday. You will assess this patient, but do you need to assess the patient right now? They didn't say the patient has a closed tube drainage and there's blood in it. They didn't say the patient has a fever. So that look like this patient. You will see the patient, but not right now. A client admitted to the hospital for observation who has absent bowel movement or absent bowel sounds. So absent bowel sounds tells you something is definitely going on in the bowels or in the stomach. So this patient will need assessment as well. A client who is undergoing surgery for a hysterectomy on the following day. So this patient just needs teaching. You need to teach these patients NPO and all those things. Surgical preoperative care is what the patient needs. So with all these patients, the one that gained 4 pounds for 1 day is too much. You shouldn't gain that for 1 day. The patient already have a history of heart failure and now having shortness of breath. So something needs to be done. I would assess that patient first. For the chest, for the shortness of breath and the weight gain in 24 hours or within 1 day. So the nurse and the client mutually rank the client's needs in order of importance based on their client preference and expectation, safety, and physical and physiological needs. What the client sees as his or her priority needs may be different from what the nurse sees as the priority need. So sometimes, or in most cases, you don't have to wait for the patient to tell you what I need. When you do your assessment, you get your subjective and objective data. You'll be able to understand what the client's need is. And you also use your clinical judgment to know that, so this client is telling me he wants food to eat, but at this point, I see the client gain 4 pounds and is having shortness of breath. Which one is more priority? Because you can physically see, or you can visibly see that the patient is using accessory muscles to breathe, or the patient is congested, struggling to breathe. Then you have to go with the airway. So sometimes it's not what the patient tells you, the priority is that the nurse is supposed to follow. That's why you have to be able to prioritize clients. Now I am going to talk about disasters and emergency response planning. Disaster and emergency response planning. And this will probably be the last portion of our video. So disaster planning is any human-made or natural event that causes destruction and devastation that cannot be alleviated without assistance. Disaster is any human-made or natural event, tornado, human-made or natural event that causes destruction and devastation that cannot be alleviated without assistance. So we have the internal disasters and disasters that occur within a healthcare organization. We have the healthcare agency, fire, structural collapse, radiation spill, whereas external disasters are disasters that occur outside of the healthcare agency. So you are in the hospital and there's a collapse, you are in the hospital and there's a fire, and that's internal disaster, where there is a collapse of the building, there's radiation spill, the oxygen tank blew up, and there's a problem. So that's internal disaster. External disaster is what occurs outside of the healthcare organization. External disaster will be outside. So we have like Metrobus, or the Metrobus had an accident, and they now bring hundreds or so many victims to the emergency department. This is an external disaster. So internal disasters are only for those within the healthcare or the hospital. Now we have a multi-casualty event that involves a limited number of victims or casualties and can be managed by hospital with available resources. A mass casualty event involves a number of casualties that exceed resource capabilities of the hospital and is also known as a disaster. So for instance, you have a group of, let's say we have a building that catch fire, a story building that has like 6 floors and it catch fire from the 3rd floor. You're going to have so many patients coming. Let's say everybody in the building, or those who are present in the building, they got injured, and then they bring so many patients to the facility. Now they brought so many patients and it's too much for the facility to handle. That's mass casualty, when the number of patients that have been brought to the facility is more than the facility resources. So let's say you have only 3 nurses for that particular day, and now they have brought like 60 patients at one time. That means the resources the hospital have, the beds, they don't even have the beds for the patients no more. They don't have space to keep the patients no more. Even if they go to other floors to get the patients to the emergency, they still doesn't have space to fit those beds, those stretchers. And the nurses, they have only 3 nurses on duty today, and 2 of them had called out. So we have only 3 nurses on duty. The resources are not available. That's mass casualty, and it's always a problem. Then we have the emergency response plan, and this one is a formal plan of action for coordinating the response of the healthcare agency staff in the event of a disaster in healthcare agency or surrounding communities. So we have the emergency response plan that have a formal directive, or they coordinate how the healthcare agency or the healthcare organization will respond in case of an emergency in the community. So if you're a community hospital, you will be in touch with the emergency response plan for your area, and they tell you to know, okay, so it's going to be a storm tonight, and this is our plan we are designing for the storm in case there's a mass or there are casualties. Types of disaster: we have the human-made disasters. Human-made disasters, we have the dam failures resulting in flooding, hazardous substances accidents such as pollution. We have the chemical spill or toxic gas leaks. So if there's gas leaking, people will have carbon monoxide inhalation and all those stuff. If we have a chemical spill in the community, if we have hazardous substance like accidentally popping of the oxygen tank will cause a problem. If you have the dam that failed, so let's say the water supply system for this area burst, and then the dam starts flooding out. It was supposed to be confined within an area, and now everything is coming out. It will flood and affect the people that are in the flowing side. So we have natural disaster. We have the human-made disasters. So human-made disasters are chemical spill, toxic gas leaks. We have the dam failure because people made the dam and it has failed. Then we have the pollution, hazardous substance pollution. Then we have accidents involving release or radioactive material, resource shortage such as food, water, and electricity, structural collapse. Like I mentioned, the building, if a building collapses, is part of human-made, or fire or explosions, terrorist attacks such as bombing, riot, and bioterrorism. Bioterrorism is human-made. It's a human-made disaster. Then we have mass transportation accidents. Those are human-made accidents. Natural disasters. Let's talk about natural disasters. What are natural disasters? Natural disasters can be blizzards, communicable diseases, or pandemic or epidemic. Let's use COVID. It's a natural disaster. It's a disease that I just spoke of. We have the cyclones, we have drought, earthquakes, floods. Floods are natural disaster. Forest fires. We have hailstorms, hurricanes, landslides, mudslides, tidal waves, tornadoes, volcano eruptions. These are natural disasters. Emergency plans and supplies. So we have natural disasters and human-made disasters. So take notes of these things on the Nclex. They are not specifically going to tell you this is a natural disaster. They are not specifically going to tell you this is a human-made disaster. They will tell you there was a tornado, there was a hurricane, there was a gas leak with carbon monoxide inhalation. They brought the mass casualties to your unit. And how do you group these patients? So take note of how these questions are framed, because we have natural disasters and artificial disasters, artificial or human-made. Then we have the emergency plans and supply. So for every disaster, whether natural or human-made, there is the need to have an emergency plan or emergency supplies in place. I'm not going to waste too much time on these supplies. It's just for your knowledge. We have a plan, a meeting place for family members. This is how you protect your own self. Identify where to go if an evacuation is necessary. So that's why every time we listen to the news, they tell you there's going to be tornado, there's going to be storm, and it's going to cover this area and that area. And you see that the lightning system, you see the telephone system, they start calling to tell you. Sometimes you see your phone ringing with an alert telling you there is an alert in the system. There is something about to happen, or there's something happening, so that you plan yourself. So you need a lot of things to put yourself in order to care for your family. You plan with your family where you are going to meet so that you be safe. You have a whistle, cell phone, work, you have gloves, you have rain gear and everything that you need. Food, water, you have the kits, emergency kits, where you have your bandages and all those things to use in case you need them. You have your lightning system because the light might go off. Now let's talk about American Red Cross. American Red Cross. American Red Cross has been given authority to the federal government to provide disaster relief. So American Red Cross provides disaster relief. And all American Red Cross disaster relief assistance is free. Is free, and local offices are located across the states. All local offices are located all over the United States. The American, they also participate with the governments. They participate with the government in developing and testing community disaster plans. So when they develop a disaster plan, community disaster plan, they test it first and they see how that plan is going to work. This is why they do a lot of drills. We do a lot of drills to make sure that this drill is going to work in case of a real emergency. Now let's talk about hazardous materials. Hazardous material. These are typically composed of emergency department healthcare providers and nursing staff because they will be the first individuals to encounter the potential exposure. So this one is called the hazmat, hazardous material team. Hazardous materials team. That's why the name is the hazmat. So the hazmat is the materials they use to protect themselves. So the healthcare providers are the first people to respond in case of a hazard. So they have all these materials they use to protect themselves, protocols, pharmacological protective gears. They have the safety measures and the methods of responding to this in case of an exposure. So that's the hazmat, hazardous materials. Is usually for the healthcare provider, especially in the emergency department. We have phases of disaster management. Phases of disaster management. The Federal Management or Federal Emergency Management Agency, that's FEMA. I don't know how many of you have heard of FEMA before, but FEMA is the Federal Emergency Management Agency. And they have 4 disaster management phases. They have the mitigation process, they have the preparedness, they have the response and recovery. So mitigation includes the following. They take actions or measures that can prevent the occurrence of a disaster or reduce the damaging effect of a disaster. So that's what FEMA does. The mitigation phase, they take actions that will help reduce the effect of the disaster. So if they tell you there's going to be a flood, they jump into this area and they start putting up bridges or they start putting up drainage holes so that to be able to drain more of the water. They start opening up those that are closed or those that are clogged on the street to make it work. So that's the mitigation action they take. They determine the community hazards and community risks, the actual potential threats before a disaster occurs. So they always do assessment. They have awareness of various community resources and community health personnel facilities. So they know the facilities that are available and their resources that they can offer. Determination of resources available for care to infants, older adults, disabled people, and individuals with chronic health problems, they also have a plan for this group of people. They have the plan for rescue, they have the plan to evacuate, and the caring for this and how to care for disaster victims. So plans for training disaster personnel and gathering resources, equipment, and materials are needed for dealing with the disaster. So this is what FEMA does. They do help a lot, and they also conduct a mock drill. They conduct the drills to be able to help make sure that when there's a problem, we'll be able to deal with it. Example is gun, how do I call it? The gun control, or the gunman, when there's a gunman or a shooter, active shooter, that's what I want to say. When there's an active shooter situation, so they help conduct a drill, or in most of the facilities, or I'll even say all facilities, they have helped to conduct a drill as to how to deal with active shooter situation. Now we have the levels of disaster. But before I talk about the levels, let me talk about the response by FEMA. And the response include putting disaster planning services into action. They put disaster services into action, and the primary concern includes safety and physical and mental health victims and members of a disaster response team. Now we have the recovery phase for the FEMA people and the actions that they take. The recovery phase, they take actions to return to a normal situation after the disaster. So after the disaster has happened, they take actions to come back to normal functioning. They cannot stay there like that. So the buildings were devastated, patients were displaced, homeless, there's no lighting. So they take actions to bring all these things back and put you back to your community. Now let's talk about the levels of disaster. We have level 1 disaster. Level 1 disaster. And FEMA identifies 3 levels. And these are the 3. Level 1, level 2, level 3 disaster. So FEMA, which is the Federal Emergency Management Organization, they have 3. So let's look at disaster level 1. Disaster level 1 is massive disaster. Level 1 is massive disaster, and this involves significant damage and results in a presidential disaster declaration. So the president will have to declare that there is a disaster. I actually agree, as the president, there is actually a disaster. And I am declaring a state of disaster with major federal involvement and full engagement of federal, regional, and national resources. So for instance, we just had a situation in Texas where a building, we had like so many people flooding in New York, New York had like flood. For 2 weeks ago, there was a flood in New York. So because of the flood, they bring federal assistance. The president came in to come and check the site or see the scenes of some of the areas that the disaster was. And it was a serious flood, which is a flood is a natural disaster though. So that was massive disaster. So massive disaster involves significant damage. Significant damage. People really lost their homes. People lost their house, their cars. They lost, the streets were all filled up. People cannot move. Cars stuck, and people died. So that's massive disaster where the president stepped in. It involved federal resources and state resources and national resources. They put in everything to put you back to normal. Like Hurricane Sandy 2012. It caused a lot of disaster, especially in New Jersey, where people are even still displaced up to date. That's massive disaster, level 1. So level 1 is massive. Level 2 is moderate. Level 2 is moderate. So moderate, that is likely to result, this is the moderate type of disaster that is likely to result in a presidential declaration of an emergency with moderate federal assistance. So this is not as crazy as the first one, the massive level 1. Level 2 is a little mild, it's moderate, but it also has a tendency of having the president declare a state of emergency. So take note of level 2. Level 3. Level 3 is minor disaster. That is likely to result in presidential declaration of an emergency. Oh, yes. Level 3 is minor disaster that could involve a minimal level of damage, but it could result in presidential declaration of an emergency. So the president will declare as a minor emergency, but the injuries or the effect will not be too much like level 2 and level 1. So 3, disaster level 1 massive, disaster level 2 moderate, disaster level 3 minor. They both have a tendency of the president declaring disaster, but level 1 does involve a lot of massive destruction. 2 is moderate. Nurses' role in disaster planning. So what are you supposed to do if you are the nurse in a disaster planning? We have the personal and professional preparedness, and this is to make a personal and family preparation. So personal and family preparation, which I had talked about in preparing for the disaster. When they tell you there's going to be a disaster, you have to prepare. So that's the personal and family preparation. You have to be aware of the disaster plan and the place of employment and in the community. You have to be aware where it is going to be. Disaster response. So in a healthcare agency setting, if a disaster occurs, the agency disaster preparedness plan or emergency response plan is activated immediately, and the nurse responds by following the directions identified in the plan. So they give you a direction. They tell you, in case of an explosion, this is the exit you use. So, or you have to, this is where this person has to go and shut the oxygen valve. You are responsible for shutting all the oxygen valve. And when there is an emergency or when there's fire, you shut the oxygen valve. And this is where you exit. They tell you the fire, the race, and the pass thing, what you do to be safe in case of a disaster. So the nurse will have to respond by following the directives that were given by the emergency response plan team members. So we have, in the event of a disaster, you activate the emergency response plan immediately. You don't wait for 30 minutes. You don't wait for 50 minutes. Immediately activate response plan. Now, triage. In a disaster or in a war, triage consists of a brief assessment of victims that allows the nurse to classify victims according to the severity of the injury, agency of treatment, and place of treatment. So we have triaging the victims at the site of an accident. We're triaging the victims at the scene. So you arrive here and you are the nurse, and there are victims in this disaster. So you are supposed to triage this patient. So the nurse will first, the nurse is the first responder at the scene of a school bus accident. So this is site of an accident that I'm talking about, triaging victims at the site of an accident. So if there's a school bus accident and you get there as the nurse, you are the first responder. The nurse will triage the victims from highest to lowest priority as follows. So you have the confused child with bright red blood pulsating from a left wound or leg wound. So you have a confused child. The child is confused in the accident, and then you have the left wound. The client has a laceration to the left leg, and it's a big one, and is bleeding heavily. That is bleeding either slightly or minor. Ideally, they said from highest to lowest. So a confused child with bright red blood pulsating from a leg wound. This is arterial bleeding. So when they mention bright red blood, that's an arterial bleeding. And arterial bleeding will be pulsating. That blood doesn't stop. It comes like a pipe. It goes fast. So that means that's an arterial rupture in there that the blood is coming from. So arterial bleeding, it has to be stopped right away. If not, this child might die soon. And the child is already confused. That means the child might go into shock as well. A child with a closed head wound and multiple compound fractures of the legs and wound. Closed head wound with multiple compound fractures of legs and wound. This is also another child you would want to triage right away. Closed head wound. You don't know what's going on in the head. Then we have a child with a simple fracture of the arm complaining of pain. Simple fracture of the arm complaining of pain. So this is another patient from highest to lowest priority. You group them. Then sobbing child with several minor lacerations on the face and hands and legs. They said they are all minor. So remember, it's an accident. So you group them according to severity. Simple triage and rapid treatment start. So you have a simple triage and rapid treatment. That is START. That's an acronym, START. And it's a strategy you use to evaluate the severity of injury of each victim as quickly as possible. And you tag the victims in about 30 to 60 seconds. So when you come to the scene, you have to tag the victims with color code. You have to tag them. So you are in this, you are red, you are green, you are yellow. You have to tag the victims within 60 seconds of your arrival. So in an emergency department, triage will consist of a brief assessment of clients that allows the nurse to classify them according to their need. For care and establish priorities of care, the type of illness or injury, the severity of the problem, and the resources that are available will govern the process of the triage. Now let's look at the emergency department triage system. I just talked about tagging the patient with color code. Use the acronym START. That's simple triage and rapid treatment. Simple triage and rapid treatment. So a commonly used rating system in an emergency department is a 3-system method that uses the category of emergent, urgent, and non-urgent. So a 3-step method: emergent, urgent, and non-urgent. Those are the 3 words. When you are doing emergency triage system, this is what they use. They use a 3-tier system: emergent, urgent, and non-urgent. So these categories, they may be identified by color coding or numbers. So color coding or numbers. So you use the priority 1, priority 2, priority 3, or you use the color code. So the color code will be red, yellow, and green. We all know that everywhere you see green, you are not actually worried. Red, yellow, green is what you tag the patient with. So in the emergency triage, the emergent patients are those tagged with red. So when you rush in and they call you that there's a bus accident, they brought the victims here, you go in there with your red, yellow, and green tags. So for patients you quickly see and you see that this one is red, you tag them. This one is green, this one is yellow. So other nurses come in, they also know. So the red has like 5 patients. So you have 6 nurses, the 5 of them will tackle the red patients. And then you have two yellow patients. Then one will tackle that one. And then when you finish the red, you come to yellow. You tackle patient tagged with yellow before patients with green. So patients with green are minor injuries. They are non-urgent. They can survive with time. But the red are people who cannot survive. But when you get there and those who are already gone, pulseless patients, they tag the patient is no pulse. They tag them with black. You can't do anything about them. It's better you save those with red right now than to jump to black. The patient is already dead. You don't need to go back to try to revive the patient. You try to save those who are still alive and can make it. Now let's talk about client assessment emergency department. So we have the primary assessment and the secondary assessment, and we are done. So for the client assessment, in the case of emergency in the emergency department, or in case of a disaster in the ED, the purpose for primary assessment is for you to identify any client's problem that poses an immediate or potential life threat, or threatening, or is a potential threat to their life. The nurse will gather information that is through subjective and objective data on the findings, and then you find any abnormalities, immediate initiation, and then you immediately start your intervention. So the nurse will gather information through objective data, and on finding any abnormalities, immediately you initiate your interventions. The nurse will now use ABC, airway, breathing, circulation, as a guideline in assessing client need, and assess a client who has sustained traumatic injury for signs of head injury or cervical injury. If CPR is needed, you use CPR, compression, airway, breathing. C, that's the CAP, C-A-B, CAP, compression, airway, breathing. You use that if the patient needs CPR. Now, the secondary assessment, the nurse will perform secondary assessment after the primary assessment. So after you have given an initial assessment, you go back for your secondary assessment. So you do a secondary assessment for your patient, and that comes after the primary one has been done. So secondary assessment will identify any other life-threatening problems that a client might be experiencing. So you were fine before, but right now I'm doing secondary assessment. I see you bleeding. I see you going to the bathroom and all you're cooking is bloody. So the nurse will obtain subjective and objective data and include a history, general overview, vital signs measurement, neurological assessment, pain assessment, and complete or focused physical assessment. So this is what you will be doing in case of a disaster. For those who think about critical pathways in disaster management, critical pathways are mostly used by facility leaders. And disaster management, you, the nurse, you are the first responder. You are the first emergency responder at the scene. So remember that. In disaster, you tag your patient with color code. We have the emergent, we have the emergent, urgent, and non-urgent. Priority 1, priority 2, priority 3. Then we have the color codes for them. So the emergent priority 1 has a color code of red. The emergent has red color. Urgent has yellow, and non-urgent has green color. Black is for patients who are dead, patients who will not survive it. So they are the patients you don't have to worry about. So when you get to the scene, tag this patient within 30 to 60 seconds, and you start providing care. That is what you're doing in disaster planning. And remember, we have natural disasters and we have artificial or human-made disasters. So try to get the differences in the disasters. We have the artificial disaster or human-made, or the natural disaster. And the nurse is the first responder, I state. And when you are in the emergency situation, or you are the nurse, you have to do primary assessment. That's the initial assessment. And then you come back and follow up with a secondary assessment. So you gather your information and you provide care for this patient. Nclex is going to want you to be able to manage disaster patients. When you get to the disaster scene, you should know the first thing. You are the first responder. Tagging the patient is key. 30 to 60 seconds. You don't spend 2 hours tagging the patient. And then you assess that you start looking for which patient to care for. So patient you have tagged red, you're supposed to care for them first. Patient you have tagged yellow, you're supposed to care for them next. The patient you tag green, They are the last one. They are minor injuries. You are not really leaving the red to care for green patient. Thank you so much for being with me, and thank you for staying with me throughout this video. I hope this helped you in your preparation as you study for the Nclex. You can contact me, send me a message, email me if you need any further clarification on this, and I'll be more than glad to assist you. Thank you so much, and have a great day, and enjoy your studies to try to pass this exam one time. Don't go and come back. Make good use of this content information and use that to answer questions correctly. You analyze them. Remember, they analyze the questions that want you to do analysis and applications at a passing level. Don't look for recall. Recall questions and understanding questions will not help you. But remember, in general, we have the 25 non-counted questions, the 25 questions that does not count towards your grade. Okay, so I want you to be able to beat Nclex, get your license, and join me on the floor. Okay, goodbye. No. I'm